is one of the highest causes of mortality, not just in India, but also globally. It's one of the top 5 cancers. A lot has changed in the diagnosis and treatment of lung cancer in the last couple of decades, and especially the last decade. But what does that actually mean for patients in India, right? We have a rocking panel here, which I'm really looking forward to speaking with, where we will discuss the advances, the improvements in technology, uh, the options available for screening and treatment, but also what are the challenges in access to care. And we have a panel which has Dr. Shewanti Limaye, who is the Director of Medical and Precision Oncology at Sir H.N. Reliance Foundation Hospital. We've got with us Professor Rekha, who's in the Department of Pathology, Molecular Genetics at CMC Vellore. We've got Mr. Vivek Tomar, who is being a patient advocate. He's a caregiver. He's runs a patient support group for lung cancer, and he's advisor to the government and various NGOs, and also runs an NGO called Rise to Survive. So, as I said, we have a very interesting panel, which I'm sure will lead to a lot of insightful discussions, and I'm sure it will be very useful to everyone out there. And I'm Aparna Mittal. I'm the founder of Patients Engage, and I'm the moderator for this session. Also a reminder that next week on 23rd, we will be discussing with Dr. Amit Rothan and Dr. Alex Thomas on the progress in lung cancer, the screening and diagnosis as well. So, you can join us then, or you can share it with with other people that you think would be interested. This entire series is supported in public interest by Roche Diagnostics India. And a quick reminder for those of you who are new to Patients Engage, we are an online platform for patients dealing with chronic disease and their caregivers to share their personal experiences, learn from each other, healthcare professionals, and to make critical decision-making process easier. We really do believe that people should not have to deal with this alone, and we work actively with various healthcare professionals and patient support groups as well. So we do believe that informed patients lead to better outcomes. So please, that's really what our mantra is. And a quick reminder also that this session is, as I said, is sponsored and supported by Roche Diagnostics. The views expressed in the video are of the speaker and are intended only for general awareness. The information discussed does not replace a medical consultation. So please consult your doctor for specific medical advice or reach directly to the panelists here. And the views do not reflect those of the publisher, which is Patients Engage, and or the sponsor, which is Roche Diagnostics. And as always, you can contact us on our social media channel, or you can write to us at editor@patientsengage.com. This session is being streamed live on Facebook of Patients Engage and Roche Diagnostics, and also LinkedIn of Roche Diagnostics, and YouTube of Patients Engage. So let me get started. So I will start with you. Thank you once again to the panel for joining us on a Saturday evening. Dr. Shewanti, if I can start with you to, set the stage with what is lung cancer and what are the early symptoms?
So lung cancer is abnormal growth of cells that lead to a tumor formation that is cancer. And if it happens in the lung, it's lung cancer. Lung cancer primarily, traditionally actually was classified as small cell lung cancer, non-small cell lung cancer. In the new age, we know that small cell lung cancer is kind of rare. So in the new age, I say non-small cell lung cancer is divided into 2 kinds. It's driver mutation positive and driver mutation negative. And that's the broader classification that we should all be aware of now. And that just means that genomic analysis is imperative in lung cancer. And without that and biomarker testing, you cannot describe the type of lung cancer. It's very critical. It's inherent that we identify the type of lung cancer, because the treatment and prognosis changes based on the type of lung cancer recognized.
Right. Thank you. And what are the early symptoms typically?
The tragedy is that lung cancer does not really present with early symptoms. That's the biggest challenge for lung cancer. By the time symptoms have actually happened, it may be locally advanced or advanced. So what I'm going to say right now should be taken with a lot of attention, and we should not take these symptoms lightly. More than 2 weeks of cough should be studied carefully, should be investigated. If you have someone who has cough and weight loss, that's a red flag. If you have someone who is having a hemoptysis, blood in sputum, significant weight loss, shortness of breath, these are all basic symptoms that could actually point towards lung cancer. They could certainly be infection, but you need to get investigated. And so getting to the right doctor, the right center is most critical.
Right. We will come to that in just a minute as well. And this is to all of you. Given the high, kind of mortality rate of lung cancer, are there any screening guidelines that anybody is aware of, especially in an Indian context? Dr. Shewanti again.
If I may say, so Indian context is a big question mark, because I don't think in India we are pursuing any screening guidelines. But that is the real agenda, why I'm sitting on this meeting and why I have made myself accessible to all awareness programs during this Lung Cancer Awareness Month, because we need to at least protect the at-risk population. Problem is, in India, we don't understand what is the at-risk population. There's one type of lung cancer that is caused in smokers. So, of course, smoking cessation and screening the smokers is most critical. But then there's this half of the lung cancer population in India is also about non-smokers. And for the non-smokers, the guidelines are not very clear. There's no specific flowchart. So the effort is in the area of developing at-risk population for non-smokers, and to be able to come to the masses with a guideline as to who's to be screened. For the smokers, it's low-dose CT scan that should be done on an yearly basis, very expensive. So for now, I would go with chest x-rays, at least chest x-rays yearly. That should be done for screening. Right. If able to afford, then low-dose CT scans.
Right. Thank you. Thank you, Dr. Shewanti. And I know that, as I think it is generally known that smoking is, and you've kind of also alluded to it, that smoking is a risk factor for, one type of lung cancer, but for the other type of lung cancer, are there any risk factors?
So the biggest risk factor that has become apparent in the recent times is pollution. So dust particles above 2.5 micron were found to be cited in a study where 50,000 subjects were studied in Europe. And there is enough understanding now that these dust particles have contributed. There is direct association with larger dust particles being associated with a particular type of lung cancer called EGFR positive lung cancer. Having said that, we have 2 other experts here in the panel, and we'll hear it from them, but I'm not aware of any of us doing anything for this kind of pollution level to go down, or to protect ourselves from the exposure.
Right. So Professor Rekha, and I'll come to you as well, Vivekji. What is the level of scientific evidence on pollution being a risk factor for lung cancer?
I think
because I've heard, even among the medical community, I've heard differing viewpoints, and that's why I'm kind of asking you as well.
I think right at this point in time, as we hear more and more reports from Delhi coming in, and it's not just Delhi and any of our cities that are really overly polluted, I think it's pushed the limelight back onto that issue. And I think science is growing in this area. The biology of it is being screened. And as Dr. Shewanti pointed out, there's enough evidence to indicate that, there is a direct link between pollution, uh, between particulate matter, which is in our environment, and between lung cancers. So the people are certainly at risk, and the risk is heightened when the pollution becomes excessive. So since there is an association and there's enough evidence which is gradually streaming in, I think it becomes imperative that we all, like Dr. Shewanti said, that though we directly aren't doing something about it, but as a policy, as people, I think we need to step forward and work towards, policies that could bring about reduction in it in some ways.
Right. Thank you. Thank you. Vivek ji, I'm going to ask you two questions. One, I want you to tell me what is the level of awareness on, the screening recommendations, even for smokers, right? Because you work with patients, you work with various communities. While there are no screening guidelines overall, but there is a general, it's always known that smokers are at higher risk, but do you get a sense that there is an awareness on the fact that smokers should be, or people who've had a history of smoking and, number of packs of cigarettes, they should be screening themselves either through chest x-rays or through low-dose CT scans?
Okay, so that's first question. Answer is zero. Honestly, answer is zero. There is no awareness or understanding or even simple knowledge of that there is something called that LDCT could help. And I would go what Dr. Shewanti mentioned about the chest X-ray. This is LDCT, low dose CT is costly, and it can't. Most of us can't get it easily,
Correct.
and,
Correct.
but uh, at least in the middle class and lower middle class, this because of those so many labs in India, people do get annual or twice in a year the blood test, but they don't go with the X-ray, which will cost almost the same for any blood test. And X-ray is the, I think, if there is something, it is the most cheapest way people can see if there is something, and then obviously with the right clinician, they can get, if something needs to be worried. And this is, in patient community, we see about lung cancer as an accidental diagnosis. So 95% are diagnosed when it is already metastatic, especially like in brain or other part, and there are symptoms. Before that, there is nothing. So the point of coughing and everything doesn't come in. So I have so my other NGO, which is ALK Positive India, has ALK positive patient of almost every state of India, and I have only 3 patient in this large group who was diagnosed at early stage, and all 3 cases were accidental cases. So one in actually in an accident, and when they done chest X-ray, they found something and they found, and then other was going for some surgery, hospital do the complete test, and they found it, and that's why they for one in stage 1 and 2 other in stage 2, locally
Right.
metastatic, they were getting diagnosed. And just couple of more points here, that lung cancer is turning into epidemic in India. You mentioned, we were discussing about pollution and everything. As per ICMR official data, by 2025, lung cancer is sevenfold increase. And if we put non-smoking lung cancer as a separate cancer, it will come in the ranking of seventh in all the cancer in the mortality rate. So that's how dangerous it is. And unfortunately, when I was traveling during the month of October, I saw in Mumbai that there was pink. I saw in Hyderabad that Charminar was pink. We are in November, except you and us sitting here discussing. I don't know how many listening. Nobody's talking about it, despite the fact that lung cancer. Even if we go for the smoking perspective, if we people who do smoke, it has peer pressure. It has status, celebrity status. Everyone do smoke. Even 12th, grade students I see, they do smoke, and no one
Correct.
was challenging them.
Correct.
But when someone got diagnosed, the question came, आपने तो स्मोकिंग किया होगा, you must have
Hmm.
smoked, इसलिए आप किए हैं, means then government say no research, government say no policy, nothing come in lung cancer, even family friends they blame. Despite that, now 50% of, at least 50% of new lung cancer cases are non-smokers, female and young. As young, I have personally met of 10-year-old boy with
Wow.
cancer in India. So that's how the bad situation is. And now every day newspaper in Delhi NCR, they says you have taken 35 cigarettes today if you have breathed, but that's it.
That's
What
it.
after that? Okay, and it cannot come as a policy that remove the pollution. It will come only with a movement.
Right.
Otherwise, not, if not us, our children and generations to come are going to die.
Right. I think that is really what is very critical. We
If I can
notice.
add in a
Sure,
bit,
sure,
and
sure.
I think even Dr. Shewanti would second me on this. We do not have very good registries in India.
Yeah.
So what Mr. Vivek is pointing out is that, you know, there is the incidence of it is so high, but we probably don't have the right numbers to put out.
True.
Uh,
True.
what numbers? The last, which was quoted per as per the registry in 2022, may not be accurate at all. So there is a lot to go, whether it's lung cancer or any other form of
Any other.
cancer. We really
Right.
need a better system of documentation, and it should come from governmental agencies. That's
Right.
where it should begin, and we need better registries to start with.
Right. Right. And I think, Vivek ji, you made an important point, because when I started Patients Engage, we really struggled to get lung cancer survivors to talk, right? And it was, one of course was because the survivorship was so low, but also because there is this blame on, cancer survivors, especially lung cancer survivors, because of the fact that they were seen as smokers. I think it's only in the last few years, unfortunately, because of the growth of non-smokers, there's at least been a greater willingness for survivors to come out and talk. But I do want to go back to you, Vivek ji, on we talked of the typical treatment pathways, and we talk of typically going to a GP when you feel early signs of cough, etc. And sometimes people ignore that cough. And now it's actually become more complicated with pollution, where you think of it as pollution related allergies, right? So you could go through, I know so many people who are constantly kind of having some chest issues, and they think of it as allergy, right? So how do you see this happening from a patient perspective, and how do you see uh, and this I'll come to you. I know, Dr. Shewanti, you said 2 weeks, but how is that? And also, we have a high incidence of tuberculosis in the country. So how can a patient navigate this more effectively going forward? And this is to all of you. So I'll start with you, Vivekji.
Okay. So obviously GP is always the first point of contact.
Mm.
And traditionally to till now, and unfortunately lung cancer is that cancer which has highest number of misdiagnosis. So if I consider my wife case, so I believe she was already metastatic years before, because earlier she was misdiagnosed with migraine, and then years of treatments. When we go to the a big center, she was misdiagnosed with brain tuberculoma, and after 6 months, and at that time there were 6 nodules, then when it become 10 mets, then they came to know that it is lung cancer metastatic to brain stage 4, 6 months to survive. So she survived 5 years, the longest survivor, because of research and lot of other factors. Okay, coming back to the story, that so still the issue is, and this is genuine issue. We can't blame it, but I think it's a true partnership, which I should focus on awareness. Awareness in patient community, and awareness in medical community, and awareness in the government community. So because we do, our 40% of India population is having the tuberculosis, one part of life, or they have that microbe there. Okay, if it is still not active, but they have 40%, and this is a huge number. Even if we do the LDCT, false positive chances are high. So that's why if X-ray should be a common practice if something happen, and if there is something happening during the X-ray, or even in the brain, there are some symptoms. X-ray should be more adapted. It has comparatively less side effect, and the clinician can correct me. And so we go to GP, and then again they give prescriptions. Then if not goes away 2 weeks, they will write some tests, and they will write blood test. X-ray, I think it will come, or CT scan will come very late, and then again it will go to TB, still TB.
Still
So
TB.
still TB, still in very high number. And I think there is a fact that ignorance that it can't be cancer from the patient community as well as from the medical community. And then the best practices which may no longer be best in India. What is happening, the best practice is, okay, ये तो हो नहीं सकता, how many lung cancer, and let's do this, and it goes 6 months and 1 year, and by the time it is metastatic, and it is too late. It is very, very late. So I think if there could be many takeaways, but if another takeaway I would take that from this call, and because Dr. Shewanti is here, who actually medical community listens very carefully. So I would request her and others that even in medical community, if we can raise more awareness. And obviously I am part of National Cancer Grid, we are talking of protocol. I'm part of Punjab government advisory board, I'm trying to create protocol, but it's not easy as a patient community. But something about it, that how without increasing the cost, how would create and see, okay, it could be lung cancer if this is happening, and if it could be that happen, what could be done. Because it will not take mountains to move this. We cannot have the perfect in India. Our 50% almost population cannot afford in any test, and we will come on the testing bit later, not commenting. But the issue is our healthcare is completely out of pocket. So that means it, how we can as medical community and patient, and then pressure government to create some, if not policies, but best practices to identify that anything could be lung cancer, especially now when people from 10 years to 90 years, smokers to non-smoker to never smokers, and the tagline is anyone who have lungs can get lung cancer.
Correct. Yeah. Thank you, Vivek ji. Dr. Shewanti, do you want to comment?
Yes, sure. So that's why I'm a huge fan of Mr. Vivek. He just articulated so well. And of course, it comes from a very sensitive personal angle, and that is empowering. Just his words have to be taken with a lot of attention. So 2-3 things that he has said just now. One, revolutionary. He said this has to be within us, the masses, right? So yes, the medical community, one has to push the awareness there. Problem is that we as the torchbearers, most oncologists, Professor Rekha here, pathologist, we are after the fact. We have to now wake up the masses before the fact. So when I go and inquire who is doing the screening effort, it's always a separate section. Separate section of screening, that belongs to someone else. So we, the warriors who are fighting with the cancer, against the cancer, are actually not involved in the screening measures. So I think we need to take ownership. We need to come on this side, and we need to help generate this as a revolution, is what Mr. Vivek just said. We have to really bring this up from the masses, by the masses, the awareness, and as a revolution. Second, he talked about cost. When we talk about cost, and cost being out of pocket, it will sit in with every human being in India that is paying out of pocket for their healthcare coverage. That actually it is much easier to invest in screening than to invest in treatment. Right? So once this idea goes in, just look at your own families, right? We all belong to middle-class families. Look at your own families. How many of our families are getting screened? Just a simple question. Forget about educating, bringing awareness to the 99% of other part of India. Just talk about your own family and extended families. And lastly, developing the right tests. So that is the biggest clincher here. I don't think there is a right test. So chest X-ray, low-dose CT, chest X-ray, inexpensive, low-dose CT, expensive. But chest X-ray, inexpensive, missing a lot of things, low-dose CT, capturing but false positives, expensive. So there has to be another method. And in that, I've been working with companies for liquid biopsy for detection of cancer, early diagnosis of cancer. Whenever a field moves, obviously, the pendulum swings on the other side. So there are some false positive concerns coming up. These tests have to become nuanced, but these are the tests of the future, hopefully not too much of a future, hopefully in the next few years that it will become a reality. And the idea would be to then triage patients. So you saw something, you did the test, that has to be very, very cost effective. And then you figure out if the test comes back as positive, then you triage the patient for the biopsy, for the further workup, versus you manage the patient conservatively. This becomes imperative because of TB, because of post-COVID changes in all our lungs. So I'll leave it there. But the one message, if I have to leave you with here after what Vivek ji said, was we have to revolutionize this movement.
Right. Thank you. So coming back to you, Dr. Shewanti, on, you said X-ray is not conclusive, and I'm just looking at it from a patient standpoint, right? But it is still the first line of at least for screening, right? And then if there's suspicion, they go to low-dose CT. And I know that in COVID, for instance, because of low-dose CT, that was another reason why people got diagnosed actually slightly earlier. What is the role of sputum cytology? Is that at all relevant in the diagnosis phase, or it's only later or earlier?
So routine sputum cytology is not yielding. I'm forgetting the name of this very high profile testing where from sputum cytology, they are predicting cancer cells in the sputum. They're predicting lung cancer. I forget the name, but when I posted on Twitter about this liquid biopsy that was predicting early cancer, lung cancer, someone posted about that sputum cytology actually being able to pick up cancer cells. So I think that's a high-end test. Routine sputum cytology would not be able to yield as much to diagnose cancer yet. I would go more with gold standard application right now is low-dose CT. If we don't have that, then work with chest X-ray and a lot of AI effort in chest X-rays. We are hearing from everywhere. AstraZeneca is working with a company called Cure AI. They are working on AI-based understanding of lung nodules picked up on chest X-rays. Having said that, we all know that chest X-ray would still be substandard.
Right. And again, the question that we've received often is, what is the role of a lung biopsy? Because I think something about the term biopsy or the process biopsy often scares patients. And this we've seen across various cancers as well. So what is the role of a lung biopsy, and are there any risks associated with it?
So I will answer clinically, and then we can pass on to Professor Rekha for her input on the biopsy yielding the right tissue. From a clinical perspective, lung biopsies have to be done with a lot of caution. They can lead to pneumothorax and lung drop. And if we are biopsying a smoker, they already have emphysema or COPD from years of smoking, and they have large bullae that could burst and cause the lung drop. So this could become life-threatening. So one has to do it in the right hands. But having said that, lung biopsies are the main means of diagnosing cancer till now.
Right.
Till now, liquid biopsy has not replaced tissue biopsy, tissue diagnostics. And so we must keep our minds open to getting the biopsy done and getting it done quickly in the safest hands, because it could help diagnosed early. It could
Right.
help start treatment early. It could help prolong survival. And over to Dr.
Yeah.
Pai.
Okay, so I'll first speak about liquid biopsy that Dr. Shewanti had referred to earlier. So for the sake of better understanding for some of your viewers and listeners who may not exactly know, when you talk about a biopsy, usually people attribute it to a chunk of tissue being removed, correct?
Correct.
So
Correct.
the terminology liquid comes from the fact that it is a very non-invasive procedure. All we're looking for is about 8 to 10 ml of blood being drawn from the patient. We then add it into tubes which are meant for cell-free DNA. They're called as cell-free DNA tubes. And then there's a protocol for collection and transport. And once it reaches the lab, we then look for a specific fraction of the tumor itself, which is referred to as circulating tumor DNA. That is, every cell tends to lyse. That's a normal physiological process. As they grow, as there's senescence, they tend to die. So when they die, they release some of their cellular content, which is the nucleic acids, into the peripheral circulation. So this is what is happening normally, even in normal individuals. But
Right.
in individuals who have a tumor, some of the DNA from the tumor is also getting released into the circulation. So that is a fraction which we are trying to capture, and that is why they're referred to as liquid biopsies. So now to put things again in perspective of a biopsy versus a liquid biopsy. Now, the ultimate for us for diagnosis is clearly a biopsy. If you have a
Right.
chunk of tissue which has directly come from the tumor, and then you're able to call it one way or the other, whether it's malignant, not malignant, it's confirmatory. You're able to clearly, conclusively prove what the condition may be. On the
Right.
other hand, now, if it is, let's say, the patient's unwilling for a biopsy. Now, that was what she was trying to say. Have we reached a stage where liquid biopsy could be used as a screening protocol? Now, it's a fast-growing science. It does have some drawbacks at the moment. I won't say it doesn't have false negativity, can be a bit of an issue if it's not collected properly. And in very early tumors, the burden of circulating tumor DNA is not very high. So we may not be able to pick up a positive. So there could be some issues of false positivity. Again, coming back to the biopsy itself, with the biopsy, the pathologist can conclusively say whether it's malignant, and if it is malignant, the histological type, the type that goes on to the type that is
The cell,
affected.
the type of the cell,
cells
right?
that are affected. So based on that, they tell with what histological type it is. Then the one way to go further is to, I think maybe Dr. Shewanti will talk a little more about what driver mutations are and how she would look at it when she has to treat a patient. But what we would do is to go beyond a biopsy being reported, we would then actually profile it at the molecular level. So when you profile it at the molecular level, what do we mean? We run a battery of tests, which are mostly nucleic acid testing driven, which could be the DNA, we could be looking at the RNA of these cells. And by way of doing so, we look for certain changes. And if these molecular alterations are present, many of them could be targeted with a specific drug. That's when they're called as targetable or actionable mutants. And once you have an actionable mutant, in a way, it's good for the patient. If there is already a proven, a good drug available, many a times we look to the FDA for approval. And if there's an FDA-approved drug available, perhaps the oncologist would consider putting them on it. So there's a lot happening further beyond the biopsy just reaching the lab. There's a lot of testing that goes into it.
Yeah. So we'll come back to, the tests that are required to determine the course of treatment in just a minute as well. Before that, I think we've received a question, Vivek ji, for you, and I also want to link that to a follow-on question is, just as in breast cancer, you have these mobile mammogram clinics, etc. Although the efficacy of that is questionable, but is there any similar, are there similar initiatives to put low-dose CT in mobile vans and, use that as a way to reach to provide geographical access, for instance. And my other question on that is, has COVID changed the accessibility of low-dose CT, both from availability of testing centers as well as coverage under various state, center, government health schemes?
Okay. So the simple answer to first question is no. Not a single initiative across India. Forget about the mobile vans. Uh, we have to be honest with ourselves and to understand even LDCT is not being recognized and used where it should be in the good hospital setup, though there are low dose CT available, but not for this purpose, not for prescribing as because I think a simple guideline from the government who may not drive it but would help, because then clinician would be feeling more empowered. There is a guideline, and the thing is we may have only one Dr. Shewanti or Dr. Pai who may be sitting in Mumbai or the Coimbatore, but there are million patients across India, and especially in
Correct.
the tertiary care centers. And the problem is, forget about the LDCT or the thing, the so-called latest treatment, for example, targeted therapies and what should be given, that has not reached to those centers. So,
We'll
and
come to that. I'm just getting through the screening process. We will come
yes.
to the...
So that the answer, no, there is nothing happening, and no mobile van would come until would be a government policy. So we have to understand, because there is legal and lot of component, and there is empowerment. So if as an NGO, if I want to start it, I can't, because
Right.
no, not as such thing until a clinician, right? The second thing, in India, everything is available without prescription. So people go to load. So in COVID time, so many people has done on its own, but again it was for COVID, because where death was imminent and people were afraid. Unfortunately, we deny that cancer cannot us, and it's a human nature. Lung cancer cannot, because I, especially non smokers, okay, I have not smoked, and how could I get the cancer again? It is again to the point of lack of serious alarming awareness that leads to so much issues. And regarding to the, I think this is kind of the answer of the second question, that we do have access of LDCT now. Because of the COVID, many of the centers have purchased those machines, and if there is one machine, low dose CT doesn't take too much time, so it covers
Correct.
lot of patients.
Lot of patients.
Yeah, so it is available. It has access, but for what? That is not there. That if people or potential patient or the patient at risk or anyone is not going into that direction. That why I was focusing on X-ray, to help audience understand that it is very cheap and available at every center. And ideally every corporate hospital who do the health checkup, they have X-ray part of package, so it is not dangerous or like that type of side effect, even if that is not happening. And I would like to summarize. I think the biggest problem is again here is stigma, lack of awareness, and that lung cancer, and with all due respect to the breast cancer, the lung cancer is not glamorized. Even you can't find celebrity comes in support. In breast cancer month, they goes, even they found who is going to invite us, and if I invite someone, hardly anyone will come. So I don't know, Dr. Swanti, if we can glamorize lung cancer, but we should do something.
Correct.
I
Well
think we
said.
should change the color of the ribbon, right? To start with.
Very well
It's white color. It's color of politicians. If we can connect with them.
When the entire cities are gray, how do you glamorize white, right? So, but anyway, go ahead. Sorry, Dr. Shewanti.
Yeah. No, I agree with Vivek ji. I think we need to put a different kind of limelight to it. Awareness is severely lacking, and even when I say None of our families are getting screened. None of the 1% of corporate hospitals that are quaternary hospitals are doing lung cancer screening with low-dose CT. All the low-dose CTs are just sitting like that. So I think it's not the lack of awareness, it's not the lack of instruments, enough instruments. It's just a practice that has not been really put forward despite the epidemic that we are all facing. So I think it requires a mass movement, and the mass movement cannot be led only by oncologists. This has to be all encompassing. Everybody, including you, has to have, engage, have patient engage, has to come together. We all need to come together. We need to really make noise around this. I just would like to mention very, very quickly. So I'm a co-chair in the Asia Pacific Coalition for Lung Cancer. We just formed this coalition in Singapore. And I co-chair it with Dr. Daniel Tan and Dr. Herbert Loong. In that effort, the biggest effort that was put forward as the main initiative for APCLC was lung cancer screening. And as we were discussing in the forum, we realized that one of the leading experts in the forum is a senior expert from Japan. And we realized that 60% of lung cancers in Japan actually are diagnosed in stage 1A. 60% of lung cancers in Japan are diagnosed in stage 1A. And that was truly eye-opening for me. And I got so interested in understanding what were their pattern practices, how are they doing it. So they have 300 CT scanners in this small country, and at the drop of the hat, they do a quick CT, and the GPs and the medicine practitioners actually know how to read the CT scans. So they quick read it, and if there is something abnormal, they escalate it to radiology. So they are using it as the first to go test instead of waiting. So a patient has cough, would get a CT scan. Maybe I'm generalizing it too much, but I learned that, and I realized we are definitely living in a resource-limited country, but we don't even do chest x-rays. So the point I'm trying to make is we need to become aware, we need to develop our policies, we need to figure out what would be most cost-effective screening or treatment.
Right. Thank you. So I'll come to the last segment where we will talk about the other tests that we need to do, right? So I think one of the challenges in cancer treatment is at every stage there are, test after test after test, as people think, but you need all of them and they all have a role. So I think it's always important. I think patients and families don't understand the role of each of the tests. So when we look at the tests that determine the one, if you can quickly touch upon the tests that determine the extent of spread, and then we can talk about the tests that determine the treatment pathways. So if you can quickly touch on that first, Dr.
Sure.
Shewanti.
So PET scan and brain MRI, very quickly. PET scan and brain MRI, and if someone can't get the PET scan, at least CT, chest, abdomen, pelvis with contrast, and brain MRI with contrast, most critical. Because of what we heard from Vivek ji regarding his wife. And this is a known fact that mets from lung could go to the brain. And PET scan will only detect a centimeter and over lesions. So PET scan, not the best test to assess the disease in the brain. Brain MRI is most critical, has to be done alongside the whole body's imaging. That said, the next is, so I say this all the time, that we need to, in lung cancer specifically, and because I'm a precision oncologist as well, in all malignancies, I say that, but now the masses need to factor in for the scan, the biopsy, and the genomic analysis. I think that much we have to factor in our minds, that if someone is red flagged for cancer, they would be undergoing scans to stage them, biopsy to figure out which type of cancer, and genomic analysis. The patient should be asking, like the patient asked, "Meri biopsy hogi kya?" The patient should be asking, what kind of mutation am I harboring? Do I benefit from genomic testing? Should it be done? Can I carry it in my family? Stuff like that the awareness needs to be there. So precision awareness, I call it, but it should be incorporated or envisioned by the patient's families, GPs, whoever are working in the field of cancer. Diagnosis of cancer, think genomic analysis. So in lung cancer, very critical. But like you said, screening is much cheaper than treatment. So diagnostic tests for treatment are much more expensive. We are struggling with the cost, and the application of those tests are even more expensive, because once the test is done, you need the drugs. And the drugs are quite expensive, even though you have several on generic now. But those are the challenges that India is facing.
Right. Professor Pai, I think Dr. Shewanti talked about things like biomarker testing, driver mutation testing, etc. Can you kind of explain that in simple terms to the audience and as well? You're on mute.
Sorry about that. So biomarker testing has become a very important part of what the oncologist would require to actually plan the treatment and the next part of what goes on for the patient. Now, when it comes to biomarker analysis, there's a lot that can be done in the laboratory. Again, just like we've had constantly through this discussion, biomarker testing can be different things in different places. Very small labs may not have access to large panels to look for many different mutations and things like that. Even then, to make it a little easier, the initial approach by what is called the Association of Molecular Pathology was to look at just about 3 driver mutations for which drugs would be available mostly. There are FDA-approved drugs, and that's how people used to initially go about it. So these genes are referred to as EGFR, ALK, and Roche, and those who carry a mutation in any one of these would be treated. So that's how the initial approach to lung cancer and molecular profiling was just limited to these 3 genes. Right. But gradually over time, what people have realized is there are many more genes which could be carrying a driver mutation and which could be treated as well. So the panel-based approach has now expanded for the panel to have a large number of different types of genes which could be carrying mutations. Now, mutations is a very general terminology that I'm using here. There could be different types of mutation. When we say mutation, it could be a simple change in the DNA alone. It could be many copies of a given segment of the DNA made. It could be that some DNA part of DNA has translocated, means moved, located, relocated itself to another part, leading to a new type of protein. So there are many different things that happen in context of molecular changes. Now, the lab has the ability to pick up most of these changes. Now, the question would be, what will you do with these changes? So that's where the oncologist again comes back into the picture. Many of them are targetable. When we say targetable, it means that because there is a change, a particular pathway, in the cell, a cellular pathway is getting affected. And whether there is a drug which can help to counter that. So that is the question that needs to be answered. And this is putting it in very layman terms, that it is possible to actually go ahead and, look for these mutations in these patients. So that's referred to as biomarker testing. Yeah.
Right. Thank you. Thank you, Professor. Vivek ji, I know that over the last couple of years, we've seen that earlier it used to be for each of these gene mutations, people needed to test again and again and again, right? And I think now there are panels that are a bit more accessible. What I'm also hearing is that the time to get the results has reduced as well. From a patient perspective, what are you hearing from the patient community? What are you observing? And, what are the challenges? I mean, cost is obviously still a huge factor, but what are some of the other challenges that they face in accessing this?
So I always say that in India, tissue is the issue. Okay, and the reason is, so I will go step by step. First is for the biomarker profiling or NGS testing, the lack of awareness and different type of lack of awareness. When it goes to the far India, uh, biomarker profiling awareness and adaptability is nowhere. It
Hmm.
is centric to tier one or tier two cities now. Well, one,
Right.
and for every tier one, every patient, tier two selective, tier three onwards, it is not there. Okay,
Hmm.
it is
Hmm.
still chemotherapy and the
Correct.
brain mets, whole brain radiation, not even talking about SRS. So
Hmm.
again, the guideline, the protocols, even medical community, and I'm sure Dr. Shewanti would be, looking at me what I'm saying, but that is required, and we have 0.98 oncologists per million population. So it
Hmm.
is wrong to blame or put everything on oncologists. That's why I say it is a partnership. No
Right.
one can do. The second lack of awareness is that so if there is no the data of mutation is sparse still in India, but if a multi-institutional study suggests that 30% of patients are EGFR and
Hmm.
10% of ELK, so that's why where they do biomarker profiling, they would go still only for EGFR, and then if EGFR negative then goes to ELK, Roche rarely, and cross no one. I'm talking about tier two cities onward. Tier one,
Hmm.
it is completely NGS
Still.
panel.
Right. Right.
And my view, India has such a large population that in India, nothing is rare. Rare is not rare in India.
Hmm.
Even
Correct.
if you can find hundred of patient of CRAS and they are struggling or ROS one and the treatment is there. Okay, so that's why the complete panel has to be done. So
Hmm.
that's the second issue. The third issue is, and I could connect it with the cost part of testing. Okay, so there is almost no insurance and
Hmm.
definitely no government scheme which cover these tests. Okay, and that is a main rate limiting step. That's why the oncologists who are really or those oncologists who are really kind, they have to see what is the patient final condition, and then patient has to purchase the medicine. So then if they have access to complete panel, they will still go one by one to save the cost for the patient. So that's why the one thing Dr. Sivanti mentioned in one the early detection, to have a right test, cost effective right test, it is also very required. So we have the right test but not the cost effective test.
Right.
uh, the cost of our good quality NGS testing, biomarker profiling complete panel, is 100 times more than many of the monthly salary.
Hmm.
Okay, it's
True.
in lakhs. So
True.
that's how they, and then go if government put in part of the Ayushman panel or something, that could, that's why the role of us together to let government know why it is important, because we can save lives. So the 5 year survival rate in Western countries, it's like, it's normal. What why we are talking it here,
Hmm.
it is still called miracle if
Correct.
somebody with lung cancer is five. And this is the issue, and we have to show and we have to keep pushing the government that why it is required. As much you and I have right to save our patient, our family member, those 40 million people who have cannot afford anything except Ayushman Bharat, they have the equal right because they have their mother, children who who have every right to live in this world. And
Correct.
last one is, I think, which I would connect this what Dr. Shivanti mentioned, the expensive medicine, and it is about the benefit part, cost of treatment versus benefit of testing. Okay, if I do the complete NGS testing, and if my patient cannot afford it,
The treatment. Yeah.
why to do the waste patients money on that testing when the testing is very costly? If it is like 10,000 rupees or any government panel, then it's good. But if it is still asking so much money, and even in some cases it is in lakh, if you go to
True.
the something, so and if you cannot afford, and yes, there are generics available, but how? So we know that gefitinib in or seritinib or crizotinib in didn't, but they are first or second generation, and
Right.
people we need alectinib, lorlatinib, osimertinib. And we know people who are patient advocate. One of the who are one my friend is BBC, one many of you knows, and he's on chemo plus a second generation one because can't afford the third one.
Correct.
And
Correct.
that is again the reason that cost of this medicine and the benefit of testing. So this is a really complex problem. And that's why I say tissue is the issue. It is not that simple, get the things done. But the answer is simple. Answer is, again, I would connect the awareness and bit of hard work. And I know it can be done because we are not asking investment of millions of rupees. I think someone like Dr. Pai could develop a test, or I know Dr. Shewanti is working hard on the liquid biopsy, and it could be a game changing if we have a cost effective, right result, liquid biopsy, and then early detection, which we have covered, and then tissue is not
Then we
remaining
need,
the issue, but tissue has become the solution.
right, right. Thank you. I
If
think
I can
Professor
add a
Pai, you
little,
wanted to say, yeah.
if I can add a little more to what Mr. Vivek has already pointed out. There are some small schemes through the government of India now. They have what is called the Diamonds Initiative. Now, by way of trying to tell what the government is doing, it's just a small drop in the ocean. No? It's just probably the beginning, and I hope the initiative becomes much bigger. As part of the Diamonds Initiative, the government has recognized 4 hubs in India, one in the north, south, east, and west. Now, patients who go to these hubs for treatment, their testing is all done free of cost, which includes the biopsy related testing and includes the biomarker related testing. So, a good 250 patients a year or so who come to our institute are covered through this. They need to be Indian nationals, and if they are, so that's a very small scheme where you try to get their biopsy charges and the biomarker testing done through the government. But again, even if it's positive for a given known alteration, they would have to spend on their treatment. So it's just the beginning, I suppose.
Right. And I think there was a couple of days back, there was an announcement from a state government as well to cover some molecular testing as well. So I think they're starting to cover some testing, but as you said, getting the test results and not supporting the treatment is still going to be a challenge.
Also, a little bit to add that I think it's wrong to believe that every single molecular test is way too expensive. Now, for example, a clinical exome is just done with 8,000 to 9,000 rupees. While I'm not trying to suggest that 8,000 to 9,000 is not too much, but earlier, maybe about 4 to 5 years ago, the same thing would have costed 3 times the amount. So as the amount of testing, the volume of testing keeps increasing, a laboratory can actually bring down the cost because you're doing larger and larger volumes and the patient is going to benefit eventually. A lung cancer panel that we run is run for 18,000 rupees, which covers everything, Alcross, whatever. We have about 51 genes with copy number variations and fusions. So this used to be 25,000 rupees. And gradually the cost is coming down. So it's also a question of time when we do more and more cases and we are trying to, subsidize on the spending in terms of biomarker.
Right. And as you said, I think it's also, I mean, we've seen that, and, as Vivek said, we also collaborate with National Cancer Grid. So we know that when, kind of cancer institutes across the country come together, they can negotiate better prices, even for treatment, etc. So, maybe there is a way forward there as well. I think we are almost on the mark. I'll just go around, and I'm also conscious that it's, everybody's already spent an hour and it's Saturday evening. I'll just go around and ask you for your final thoughts. I'll start with you, Vivek ji, your final, what is the one key thing that you want people to take away?
So that is, anyone with lungs can get lung cancer. Be that in mind. And to my fellow panelists and patient advocate, medical community, pathologist, and government, until we change what is today, we cannot stop because losing is not an option. Thank you.
Okay. Thank you. Professor Pai?
I think it's been a very good discussion, and I should thank all our panelists for giving their views. And I think we have a long way to go still, even in terms of testing. What was yesterday is not there today. It's a very dynamic field. It's quite difficult for us as well. That said apart, I think it's also important to try and bring down the cost as far as possible and try to extend it and make it available, and like Mr. Vivek pointed out, that it may be totally absent. There's no question of testing when you go down beyond a two-tier city and to smaller places.
Correct.
So I think accessibility is the key, both in terms of testing and in terms of having being accessible to have to meet an oncologist, to be that is, I think, the key to sorting out a
Right.
whole load of problems in our country. Yeah.
Right. Thank you. And finally, you, Dr. Shewanti.
So I would like to let hope be my last message. So even as we discuss so many struggles, we are saving lives. All of us are involved. We are, I call ourselves warriors because we are there all the time. We are there with optimism. We are there with force. We are there with energy. And so we have to really get out there and seek help. It shouldn't be this difficult. But the problem statement has to be realized. And if the problem statement is testing, and testing is expensive for that patient, then there are some pharma companies giving free tests, some labs giving free tests. There could be a solution, government giving free tests. So we need to seek the problem statement, and hopefully that would then bring the patient to the right treatment. But finally, leave you with this word or this message: prevention is much less expensive, much easier on all of us, people at large, than treatment. Who wishes to be diagnosed with cancer? We need to really raise awareness and revolutionize screening. That's my message, and we all need to come together, all the NGOs, all the medical community, masses at large. Everybody needs to come together to really pivot screening. Thank you. Thank you for having me.
Thank you. Thank you to all the panelists. Yeah, thank you to all the panelists, and thanks to Roche Diagnostics for supporting this. I think to me, really, as I kind of summarize this thing, is as everybody has said, as patients, we need to, or as people, we need to partner in care with the healthcare community. And therefore, we need to start by recognizing that cancer can happen to us. It doesn't only happen to others. And we see this all the time. So we need to be proactive as, if there is any suspicion. And we need to also collaborate to work on improvement of access to care, as well as, reduce costs. So, to all the industry out there, we all need to work together to figure out how to reduce cost drivers, and also to work with the government to improve universal health coverage. So thank you once again, Vivek ji, Professor Rekha, and Dr. Shewanti.
Thank you.
Thank you. Thank you.
All of us.